So what we're seeing is, an increase in the number of survivors that are living in the country, which is a good thing, obviously. You would see that about 20 years ago, we had about 10 million cancer survivors living in the country. And now when you look at 2021, we have probably 17 million cancer survivors if you're looking at statistics from the American Cancer Society. And within 5 years, within 5 short years, so for those of you who are students, when you are out practicing and you are a new professional, right, you'll be out practicing for just a few years, 5 short years from now, there's going to be an estimated 20 million cancer survivors living in the country. And so this is one of the things that I impress upon anybody who's has an interest in oncology. We have even our colleagues who may not necessarily say, oh no, I'm never going to treat somebody with cancer. Like I only do orthopedics, or I only do peds, or I only do neuro, I'm never going to treat anybody with cancer. That's not true. With 20 million cancer survivors in 5 years, is not a question of if you'll treat somebody with a history of cancer, but when you will treat them. And so, again, if you look at the numbers again from the American Cancer Society, this is kind of where we're at now. We know that breast cancer is the most common form of cancer for females, and prostate is the most common form for males. But you can see that both for males and females, lung is the second most common, and colorectal is the most common for both men and women. And so, we have to make sure that, that we're not just thinking about breast cancer, and we're not just thinking about prostate cancer, but that there are so many other diagnoses that we have to be prepared, for that person who might be walking into our door. And so, just quickly, again, because I know that future talkers or future speakers are going to be talking about doing a little bit of a deeper dive into the different cancers and the side effects and that sort of thing. But just to quickly talk about chemotherapy versus radiation therapy. Chemotherapy is systemic. It's a systemic approach to dealing with cancer. And it's given in these intermittent doses to allow for the bone marrow to recover. Most chemotherapy cycles are given every 3 weeks. You may see something written in somebody's chart, like if you're doing a chart review, for example, you might see DD written before somebody's chemotherapy regimen, and that means dose dense, which means that they've shortened up that recovery time. So instead of 3 weeks, it's actually 2 weeks. And I wrote greater than 50 different chemotherapy agents. I'm not exaggerating when I say that. If you feel like new chemotherapy agents are being introduced almost on a weekly basis, which speaks to the level of research that's going on out there, how these new chemotherapy drugs are being developed, protocols are being changed. I know, for example, in testicular cancer, 20 years ago, they used 3 chemotherapy drugs to treat the cancer, but they found that one of the chemotherapy drugs caused pulmonary toxicity and long-term pulmonary fibrosis. And so they found that they can give the other 2 drugs 1 or 2 extra cycles and still have the same overall survival rate than by giving the 3 drugs. So now they don't use that 3rd drug anymore because of those side effects. And the reason why you will have chemotherapy given that in combination, like you would have 2 or 3 or 4 chemotherapies given at one time, is that the chemotherapy impacts cell development at different times. So the problem, though, is that because chemotherapy is systemic, that you can have a lot of the body systems affected by that. And the number one thing that I see, and probably the biggest physical complaint that we see for our cancer survivors, is cancer-related fatigue, which is really kind of the perfect storm of the cardiovascular system is being impacted, the musculoskeletal system is being impacted, other vital organs are being impacted, and it all kind of comes together, and it just leads to this overwhelming sense of fatigue that is not related to exertion, and it's not relieved by rest. Also, chemotherapy-induced peripheral neuropathy. which you can imagine, it presents in kind of that classic stocking and glove distribution. So you can imagine if somebody's got issues with their hands, that's going to affect ADLs as far as doing buttons and zippers and food preparation and that sort of thing. And a really big thing for us as physical therapists is if somebody can't feel their feet, they become a falls risk. And I think this graph, which I also shared at the PT PyTest Summit a week and a half ago, I think it sums it up pretty well. Again, all the different body systems that could potentially be affected by these different chemotherapy drugs. And not one drug affects every single system, but again, when chemotherapy is given in combination, that's where you start to see all of these concerns. So while chemotherapy is a systemic approach to dealing with cancer, radiation therapy is a much more localized approach. And it's interesting in radiation therapy, just like actually with chemotherapy, you can give it in what's called the neoadjuvant setting, which is to say that you can administer radiation prior to surgery, just like you can administer chemotherapy prior to surgery, with the idea that you're trying to shrink the tumor and maybe make it a little more manageable for the surgeon. And so, but obviously, mostly you're going to see patients receive their radiation therapy after they've had their surgery and after they've had their chemotherapy. And the radiation oncologist may also use radiation therapy in the palliative setting for pain control. And so, we have these different methods of doing radiation therapy. The most common, I think everybody's maybe familiar with, is kind of this external beam where somebody lays on the table and they actually have the device, and actually it will shoot the radiation beams into the person wherever the cancer may be. Interestingly, the hardest part of radiation therapy for the patient is what they call simulation, because they have to set the computer up to be as pinpoint as possible to try to get just the cancer and not get all the healthy tissue around there. And so that can take 90 minutes, maybe even 2 hours at a time to do that. But once that's set up, the actual act of the patient receiving radiation therapy after that takes like 5 or 10 minutes. It probably takes them longer to park sometimes than it does for them to actually get the radiation therapy. And radiation therapy is given daily over the course of a couple of weeks, maybe anywhere from 4 to 6 weeks. There is a form of radiation therapy called brachytherapy, which they use more often in prostate cancer, a little bit in the colorectal cancer as well, where instead of the beams of radiation therapy, they actually inject radioactive seeds. And the idea is that you inject these radioactive seeds into the tumor. And it's basically you're killing the tumor from the inside out. And so one of the issues that we need to think about, more of a local physical concern that we need to be concerned about is something called radiation fibrosis syndrome, which occurs in the radiated area, and where this normal tissue was in the field, in the line of fire, so to speak. And so that normal tissue becomes disorganized and sclerotic over a period of time. And essentially that connective tissue starts to bind down, and then it gets harder and harder to move, which you can imagine, limit range of motion and can lead to pain. And really any patient who's ever had radiation is at an increased risk for developing radiation therapy. I know that the radiation oncology nurses affectionately say that radiation therapy is the gift that keeps on giving, because this is something that you may not necessarily see right away. This is something that you may actually see even down the road, 2, 3, even 5 years down the road. And in this graph, basically shows on the left what healthy tissue looks like, and on the right, that purple stuff is the fibrotic tissue, is kind of the breakdown of healthy tissue, and it becomes sclerotic, and you can see how it can impinge on nerves, it can impinge on blood vessels. And so again, you can have somebody start to present with cardiovascular issues or neuro issues, depending on where that sclerotic tissue is developing. And so when we think about, again, all of the potential short-term and long-term side effects from chemotherapy, and we combine that with all of the potential short-term and long-term physical issues that we might see from somebody who undergoes surgery. And then if somebody also gets radiation therapy as well, and goes under the some of the side effects of what we were just talking about, it really does come to this perfect storm of all these physical side effects: fatigue and pain, balance concerns because of neuropathy, the decreased range of motion from scar tissue. But there are other things here that we need to consider as well. And one of the things that I see so often in our survivorship clinic at Smilow Cancer Hospital is fear of recurrence. This person has been through this traumatic experience, and they will, they'll walk out of treatment and they'll say, but did we do everything possible to make sure that we got rid of the cancer? Is the cancer ever going to come back? And so, there may be this little voice in the back of their head that's always asking, is that little ache or pain, is that the cancer? Did the cancer come back? And so we have to be mindful of the psychosocial implications of somebody who goes through a cancer diagnosis. And so, talking about where we as physical therapists and future physical therapists, where are we going to interject ourselves, so to speak? Like, how are we going to help our patients, and at what phase during this cancer experience are we going to be able to help them? And I said this earlier, and I've said this often, that there's never a bad time for a patient with a history of cancer to get physical therapy. Ideally, we want to see them as early as possible. Like, if we can see them in this prehab phase, in this preventive phase before they have surgery, we can work with them to work on some strengthening and work on some education. And we can't undersell the idea of empowering the patient in this very turbulent time. And then to be able to also work with our patients while they're in the middle of therapy. And again, just to give historical context here, 20 years ago, oncologists were telling their patients, don't exercise when you're getting chemo. Don't work out when you're getting radiation therapy. You want to conserve your energy. You don't want to be working out. And thankfully, we have now a plethora of research that says that no, it's the opposite is true. If you're able to move, you're going to get through your treatments better and potentially with less side effects. And you may even be able to tolerate treatment better if you're able to move. But that's our job as physical therapists, is to teach them how to move and how to move safely as they go through this. And then in the restorative phase, after they finish active treatment, they may still be on hormone therapy, or again, to kind of be thinking about, what's in the future for these patients, and what are some of these long-term side effects that we need to be mindful of. And again, we don't want to forget the palliative phase of care as well. As far as, again, patient safety, patient education, caregiver education is so critical at that phase. And so we obviously play a big role in that as well. So again, the idea of rehab, we're doing it. Like, if any of you have been on any of your ortho clinicals already, anybody who's going to get a total hip or a total knee replacement, they meet with the orthopedist and they meet with a physical therapist prior to their surgery. And the physical therapist says, I want you doing your, straight leg raises and your long arc quads, and I want you to do all these leg exercises to get your legs as strong as possible, because we want you in and out of the hospital in under 24 hours. We want you back up walking, because they know that, if you're able to do something ahead of time, it optimizes your function on the other side of surgery. It's the same principle here for cancer. If we're able to see these patients before they have surgery, and especially if our patients are getting neoadjuvant chemo, so right there, they're going to get tired before they're even, and they're going to be deconditioned before they even get into surgery. So we need to be working with them to get them strong or keep them strong, as best we can before they start that. And again, we cannot undersell this point. We cannot undersell this idea of patient empowerment. These patients feel like their life has been thrown upside down. They don't know left from right. They all of a sudden have all these appointments that they don't have control over anymore. They don't know, should they be telling their friends? Should they be telling their coworkers? They don't, they have all these questions. But we can give them something tangible. We can give them a stake in their health at a point where they feel like their life is spinning out of control. And that's what we can do as physical therapists, especially in this prehab phase. And then during the active treatment phase, again, we want to continue to try to see our patients as best we can. My good friend and colleague, Kelly Reed, if you're not following her on social media, you really need to. I'll put up her contact information in a little bit. She put together these graphs, and they're amazing. And the idea is that you can see, the one in the purple background there, that, with each cycle of chemotherapy, fatigue increases. It becomes a cumulative effect. Neuropathy becomes a cumulative effect. Chemo brain becomes a cumulative effect. And so what we want to do then is we want to look at these chemo cycles, and we want to say, okay, if you're getting chemo on a Tuesday, I know you're probably not going to feel great for a couple of days right after that. So I probably would want to see you Monday, but I don't necessarily want to see you the rest of the week. But if you're on a 3-week cycle, I definitely want to see you on that second and that third week, because I want to try to get you back. You took a little bit of a hit, but I want to have you start to work back up, right? And so you keep doing that through their chemo cycles. You say, okay, we will be flexible. So it's the idea of this periodization of our interventions through chemo. And that way it helps to lessen the overall decline of function that our patients see. And again, so that's another way that oncology rehab kind of breaks the mold, right? Again, we think about orthopedics, and you say, okay, 3 times a week for 6 weeks, you're coming in here and we're doing this, that, and the other thing. This is a lot more nuanced. And I think it presents a challenge, but I also think it's really exciting. And I know that our patients are very appreciative of the fact that we're willing to work with them and work around, their chemo cycles, or we'll schedule our PT sessions prior to radiation therapy, like in the morning. They have radiation in the afternoon, so that we can try to see them and still work with them. And then this whole idea of survivorship, this idea of, the person's in active treatment and it's intense, but they're also kind of wrapped in a supportive cocoon, so to speak. They've always got the doctors and the nurses and the support staff there while they're going through chemo and they're going through radiation therapy. And then they get to that last day. They get to that last day of radiation therapy and they walk out and everybody's cheering, and there's a little bell or a gong that they hit, and everybody's really excited about that. And the doctor says, okay, you did great. You're done with treatment. We'll see you in 6 months. And the patient says, what am I supposed to do now? So am I supposed to go back to work now? Am I supposed to go back to working out now? Like, what am I supposed to do? How am I supposed to start exercising again? Or did I ever exercise before? If I didn't, how am I supposed to start an exercise program? And so this is what survivorship care is this bridge, right? Like when the person gets to the end of the cliff, like we actually give them like a bridge, we give them like a rope ladder or something so that they can continue on with the rest of their lives. And I think it's really important what we do, in this survivorship phase, is that we're continuing to screen and assess for all these long-term side effects that we will know is potentially in their future. Again, certain chemotherapies can lead to cardiotoxicity. Certain chemotherapies can lead to pulmonary fibrosis. Hormone therapies for our women who have breast cancer or our men who have prostate cancer. The hormone therapies can cause joint pains, it can cause muscle wasting, it can cause accelerated bone loss. And so these are things, so even though they're not in active treatment anymore, these are still things that we need to be monitoring and assessing as they move forward with the rest of their lives. And I said this at the virtual PT Summit a week and a half ago, and I don't even know where this came from. I was talking to a group of students, I think from Quinnipiac University here in Connecticut, and there's this idea again of during this extremely turbulent time in this person's life, and again, one of the constants is inconsistency, and they don't know left from right, and treatment might be delayed because of blood values and that sort of thing. We can be that anchor for them, right? If we're with them at prehab, and we're with them during active treatment, and we're with them during survivorship, and even if it's not us, like if it's our colleagues, right? If it's, if my colleague does like the prehab screening, and then my other colleague who's an inpatient sees that person immediately after surgery and talks to them about immediate post-op exercises, and then they say, okay, and then in a couple of weeks you're going to go see Scott, an outpatient, right? Then there's always a connection there. And so that's what we can be. Like, we can be that anchor, we can be that stability for these patients. And so how are we going to engage our patients and our clinicians, not just ourselves, but our colleagues. It starts with one patient, and I know that sounds cliche, but to get that first patient that you get to treat with a history of cancer, and it may be a little overwhelming, and that's the strength of this group, right? The student and new professional group. Like, if you know that you have somebody with a history of cancer on your schedule for Friday, then to be able to reach out to anybody who's part of this committee, or to be able to reach out to any of us who are practicing clinicians and say, I've got this person coming up, like, what should I be on the lookout for, and that sort of thing. Because if you treat that one patient well, that patient's going to feel good, which is a good thing. That patient's then going to go back to their doctor and say, I was just working with Steph, or I was just working with Emma, and I, my pain is less, I can move more, I'm now, in more of an exercise routine that I was not in before. And the doctors pay attention to that. So it really can start with just that one patient. And you can't also forget the power of thank you. So when you do treat that patient, to be able to reach out to that provider, whether it's the medical oncologist or the radiation oncologist, whoever it was, just say, hey, thanks for that referral. It's been great working with Mrs. Jones. Really seeing a lot of progress. She's able to walk further now. Her 6-minute walk test has gone down, by 200 feet or whatever it is, whatever you're measuring. And so, so then you put yourself on that clinician's radar, and they say, oh, okay, well, maybe I'll send somebody else to this PT. And that's how you start to build up your caseload. That's how it starts to snowball. And I've done a lot of in-services, not just for my clinicians that I work with, my fellow rehab staff, but also the oncology clinicians, to again let them know what do we do as physical therapists, and how we can help their patients. So we do need to be advocates for our patients. I think that's one of the biggest things that we need to learn as to be in this role, is that we have to advocate for our patients. One of the things that I have learned, just really quickly, when you work in a big medical institution like I do, sometimes you have to spell it out really succinctly in order to get those referrals. So I've even gone through and I've done like these mock-ups of like, how do you make these referrals? How do you get these patients to me? Because we work in a big place and these referrals can get lost. And so I'll say like, you got to put my name on it and you got to mark urgent, so that it gets to the top of the queue, so that the scheduling queue, so that I get to see these patients. I want to take a minute, again, because I can appreciate, if you're, if this is something that you're interested in, but you're saying, how do I do an assessment? Like, if this person with cancer is sitting in front of me, like, what am I supposed to do? Like, what are the questions that I ask? What assessments do I do to see what's going on with this person? And the good thing is the APTA Oncology has developed this, what they call this edge. They developed this edge task force, and they came up with kind of this bibliography of all these different assessments and measurement tools that have been validated, that we can use in our clinical assessments. And the good thing is probably a solid 2/3 of them are already things that you're learning in PT school already, or that you're already using as a practicing clinician. If you haven't learned it yet in school, like you're gonna learn how to do a 6-minute walk test. You're gonna learn how to do a timed up and go. So those are things that you can do for any population. And the good thing is we can do that. That's been validated to use in this population as well. So right there, like you have tools that you already know, that you can start to get some sort of baseline data from that for that person who's sitting in front of you. There are some things though that are a little bit more oncology specific. And so that's where you have to do a little bit more research and learning a little bit more about, these oncology specific questionnaires, the ones that the oncologists use, because, if we are going to try to speak the oncologist language, if we're going to, kind of learn their language, we do need to at least be familiar with those questionnaires as well. So we can say, oh yes, so-and-so's, their distress on the NCC and distress thermometer went from a 7 to a 3 because, they saw this in physical therapy. The oncology clinicians know what that means because that's their tool. And so when you speak their language, then they say, oh, okay, I can see the benefit of physical therapy. And so I think one of the, when we ask this big question about how do we further oncology rehab, well, first and foremost, you're all here tonight, which is great. And this group, the student and professional group, again, like it's such a driving force and it's awesome. So as far as resources that are out there, again, definitely the EDGE task force, which is available on the APTA Oncology website. So if you're not a member of APTA Oncology, it's definitely something to consider so that you get access to that. I want to let you know that, there are these oncology residencies that are in the country, and all of those locations are on our website as well. Board certification in oncology is still relatively new. The third cohort just sat and took the test last month, so we'll find out in June who's part of that new cohort. And I can tell you, as kind of a tease, our Centennial Scholar, APTA is doing the Centennial celebration for the entire year of 2021. Each academy or section gets a scholar, and they have a capstone project that they have to work on. And our amazing Centennial Scholar, Alexandra Hill, her vision, her capstone is to create a mentor-mentee program where she wants to link formally link mentees, students, new professionals, and those of us that had a mid-career shift and were doing one thing and then decided halfway through the career, no, I want to change things up and I want to work in oncology rehab, to be able to pair us all up with an established clinician, so that way you can really talk and and feel like you're supported as you're going through this process. I know that that some of the states, and I know that some of the universities have these oncology special interest groups. I know that Duke has one now, which is fantastic. So these special interest groups, are both on the state level and on the collegiate level in some places, and so that's another great place to network. I will tell you quickly that, again, when we think about, how do we kind of justify, what we do as PTs in oncology rehab? Obviously, we have all of our advocacy through APTA, but one of the big things that is in our favor is that, again, the governing bodies for the oncologists, their guidelines in multiple areas spell out that patients need to have access to physical therapy. And so we can leverage that to make sure that we're reaching these patients. Again, these are some amazing individuals. If you're not following them already, you should be following them. Again, on Instagram, Kelly Reed, she's out in Minnesota. She puts out something every Friday. Alexandra Hill, our Centennial Scholar, she puts out some great public health stuff. If you're not listening to the OncoPT podcast, you're missing out. Elise does an amazing job with all of her interviews and all of her content and that sort of thing. I'm going to go quickly into a case study, and then I'll have time for questions afterwards. So I wanted to kind of run through, a patient of mine who I'm first evaluated back in September, and I actually just discharged her on Monday. And so for the sake of this case study, we'll call her Emily. So Emily is a mother of two boys who are 18 and 21. She's divorced, but she has a supportive boyfriend now. And last June, she went for her regular mammogram, and they found something. Interestingly, they found something in her left breast. And because she has dense breast, she went back for an ultrasound, and they ended up actually finding inflammatory breast cancer in her right breast. And so she was diagnosed with stage 2 breast cancer last fall, or actually in August. And she underwent a double mastectomy. It started off with a what they call a sentinel lymph node biopsy or dissection, where they were going to just take one lymph node right close to the tumor, but it saw that it looked like it had spread. So they had to go up into the axilla, ended up taking out 18 lymph nodes from the axilla. Because they took the lymph nodes out of the axilla, she developed something called cording, which probably some of your future presenters will be talking about more in detail, but it's essentially sclerotic tissue that develops if the lymph nodes are removed. And she had just started chemotherapy. She had just started her first round of AST, and that's when she got referred to me. And so when she came to me, she had limited range of motion. Her quick dash score was modestly high. So basically she couldn't raise her arm here. And because she had invasive disease, they knew that radiation therapy was going to be part of her treatment plan down the road, which means that she's going to have to get her arms up over her head like this. So if she can't get her arm up here like this, that could potentially delay radiation therapy. So we're essentially working on a clock here to be able to work on that and kind of break that up and get her range of motion back. So that's what I did. So first off, I started off with manual therapy. A lot of the scar tissue management techniques that you'll be learning in school is exactly what I did on her. And then because she was in chemotherapy, I worked my PT sessions around her chemo. She was on a dose dense cycles, so she was every 2 weeks, so it was a little it was a little tricky, but we made it work. She ended up getting her chemo on Thursdays, so I could see her on a Monday or a Tuesday, and then I could see her like twice the following week. And then knowing that she was going to be getting a chemotherapy called Taxol, which can cause neuropathy, I initiated balanced exercises with her before she even started that particular chemotherapy drug. So I was trying to get ahead of it. And so she said that the neuropathy really was not that bad. She got very minor tingling, like in the very tips of her toes, did not get anything in her hands. And so we sounds like we kind of got ahead of it there. Interestingly, we were actually about ready to discharge her when she came in one day and she said, "My arm feels heavy today." And that was a tip to me that I said, "Oh, if your arm feels heavy, that's different. You weren't describing your arm that way previously." So I had her go see our lymphedema therapist, and they did the bioimpedance screening, and sure enough, she was just starting to develop lymphedema. So our lymphedema therapist put her in a sleeve and said, "You need to wear the sleeve for the next 30 days. And sure enough, the volume of her arm went down because we caught it early enough. So before she developed full-blown lymphedema, where it'd be really hard to treat, we were able to get ahead of it and get that under control. And so, like I said, we discharged her on Monday. She's got full range of motion back. Her upper body function is a lot better than it was when we started. And she started going back to work. Actually, it was last week. So she said, first week was a little rough because she hadn't worked in over a year, but she was happy to be back working with her colleagues, and so it was a good thing to get her back to work. And so I'll leave you with this, and then we'll open up to questions. Probably two of the intangibles, again, for oncology rehab, we have to make sure that we're educating our patients. We have a half hour, we have an hour with these patients at a time. So we can use that time to educate them as far as, again, what's going on with them. A lot of times we're the ones that are explaining these little aches or pains, or why they're taking these particular medications, or really taking a deeper dive into what are the side effects of these different medications. And then also validating to these patients that they're tired, validating to them that they've got tingling in their hands and their feet, that they're not the only ones who are experiencing this. And when they hear that, you can just see the waves of relief washing over them. And with that, I'll stop sharing my screen.
Thank you so much, Scott. That was awesome. It was my second time hearing it, and it was even better. So yeah, we'll open this up for some questions. Feel free to either type them in the chat and I can read them out, or if you would like to unmute to ask Scott a question yourself, that would be awesome as well.
Hi, Scott. My name is Mimi Smith. Thank you so much for that presentation. It was awesome. I've got a quick question, and this is more medically related, but at the beginning of the presentation, you had talked about how there's now 50 different chemotherapy drugs that are being used. And I was wondering if you could explain kind of why, with increasing those medications, why we're still using the old ones, what are the benefits of the new ones, and if they're more related to the pathology, or why would you have variation in the chemotherapies that are used?
Yeah, Mimi, that's a great question. Some of those chemotherapy drugs that they have found are, they're very effective. But I think in the next decade we're going to see kind of this explosion of research, and I think one of the things that, and I know that I know our doctors and our researchers here at Yale New Haven and Smilo are working on the immunotherapy. Like, they're talking about doing immunotherapy for breast cancer now, which would be huge, right? And so because they're starting to use it with lung cancer now as well. And so So you can start to see how they're trying to, the doctors and the researchers, they are like, they're trying to come up with these things. But it is interesting that, for some protocols, and, and I don't mean to pick on the pediatric population, but I feel bad for our pediatric population, because those drugs are, those kids get some of these medications that are so hard hitting, and they haven't come up with anything better yet, unfortunately. So it does ebb and flow. I mean, I even have seen, even within breast cancer, for example, like kind of the classic protocol is this ACT protocol, but there are variations with that. They can maybe swap one drug in for a different one. A lot of it will depend also on family history, the risk of recurrence, the oncologists have all these different metrics now that they're using, and so some women don't get those drugs anymore. They'll get a different set of drugs. So it's always in development, and I honestly, like, I do, like, half the time, maybe not half the time, but a third of the time, I'm going on Google because I'm doing a chart review and I'm like, I don't recognize that chemotherapy. Like, I've never heard of that one before. So they're constantly being updated, and and hopefully, yes, some of those older drugs, the ones that are the more toxic ones, like bleomycin. Bleomycin is the one that I was telling you about before, that they used to use for guys for testicular cancer, but they found that it scars their lungs, and so that's why they don't use that anymore. And so I think with better clinical trials, they'll be able to say, okay, we're not going to use that one anymore. We can do, we can do a different protocol and we'll get the same output or the same outlook, doing it a different way.
Hi, Scott. My name is Emma Altna, and I had to jump in a little bit late for the meeting, so I'm sorry if you mentioned this in the beginning and I missed it. One of the things that I've been noticing just in talking with like current clinicians when discussing oncology rehab is that the current knowledge seems to be pretty limited, and like the understanding is pretty limited to just specifically individuals with lymphedema. So I was wondering if you could kind of explain the patient populations that you see a little bit more. Is it predominantly patients with lymphedema, or has the scope like widened at all?
So, Emma, that's a great question. I made this comment last week when I was talking to our breast team, our entire team here in Connecticut at Smile Hospital. I am actually the lone oncology therapist who is not lymphedema certified. I feel like I'm either the black sheep or I'm either the lone wolf or the black sheep of the group, however you want to look at it. And it's interesting because my supervisor even asked me at one point, he said, do you want to get lymphedema certified? And I actually said no, because I said, well, first of all, we have amazing lymphedema therapists already on staff, but I'm here to treat everything else. I'm here to treat the neuropathy. I'm here to treat the deconditioning. And even not being lymphedema certified, I still have enough manual skills that I can break up cording. I can do, some basic manual therapy. I can do, work on somebody's incision, to try to mobilize, some scar tissue, that sort of stuff. I don't have to be lymphedema certified to do that. But that's how I look at my role. I tell people, like, I will see anybody who walks in the door. On any given day, like, half my population is male. I mean, I'll have a male who's, a prostate cancer survivor, somebody who's had lymphoma, somebody who's had head and neck cancer. So I will see, and that's what oncology rehab is. Like, lymphedema is obviously a very specialized subset of that. But yeah, for general, I consider myself a generalist, I guess, so to speak. Does that answer your question, Emma?
Yeah, that does. Thank you.
Yep.
I had a question regarding kind of you talking about cancer-related fatigue and how chemotherapy can augment these side effects as well. So how do you balance prescribing physical activity and exercise to these patients while also kind of teaching those energy conservation techniques?
Mm-hmm. Yeah, Steph, that's a great question. And I have that conversation so often, and I don't go, too deep in the weeds with them, but to talk about, like the metabolic equivalent of different ADLs that we do. One of the things that I will bring up to people all the time is, if you look at the metabolic equivalent of taking a hot shower, that you're expending the same amount of energy that if you were going for a walk at a 15-minute pace. And when you frame it that way, they say, oh, so it's no wonder that, if they get up and they take a shower and they empty the dishwasher and maybe they do a load of wash, then they're exhausted. And so the way that I do it is, and I think that our survivorship clinic does this well in the sense that we have these national guidelines, right? ACSM came out with the updated exercise guidelines for cancer survivors in the fall of 2019. 150 minutes of cardiovascular exercise, breaks down to 30 minutes 5 times a week. Great. And what and I always, I put it back on myself and I say, I'm not a math major, but, if you can't do 30 minutes all at one time, like do 10 minutes in the morning, and then you do 10 minutes at lunch, and then if you can do another 10 minutes after dinner, well, guess what? Now you got 30 minutes. So that's where you start from, right? And that's what I say. Like I always, again, it's very cliche, but I tell them Rome was not built in a day. You just went through this really intense phase of treatment, so it's not going to happen overnight, but you can work towards it. And so again, it was like, so we take these national guidelines and we distill it down, we make it individualized for the person who's sitting in front of us, and a lot of it is goal setting. Is setting those short, attainable goals so that the person doesn't get frustrated, and then when they get that short, attainable goal, okay, great, what's the next one, right? You're always thinking ahead, like we're thinking ahead, but we have to break it down and we have to make it achievable, or else the patient's not going to want to do it.
Thank you.
Scott, what are some techniques you use for yourself working with this patient population that is really emotionally taxing, and how do you as a provider take care of yourself?
Ooh, Mimi, that's a good question. Well, I will say again, like when I am with my survivorship clinic team, which we do survivorship clinic every Wednesday, we have each other, and so we use each other as a sounding board, and we're, especially the dietitian and I, like we've been at the clinic pretty much since it started. Like, I affectionately refer to her as my work wife and I'm her work husband. We've been working together for so long. Like I feel like I'm an honorary dietitian and she's an honorary PT. So we lean on each other. So we have that. And then, I will, if I've had a tough day, like, I might just need to be like, okay, I need to go for a run, or I need to go for a walk around the neighborhood, or I need to just get on the bike and just kind of get some of that energy out. At least I see you're on the call over there, and we've had this discussion a little bit as well. Just like we come up with these individualized plans for our patients, like it's very individualized to ourselves as well. Not to go, I know it's already late and I don't want to go into it too much, but as a survivor myself, there are times that, if we lose somebody that, I experience something called survivor's guilt. And so that's something that I've learned to get better with over the years, but it's always still there. And, just the idea of, why this person and why not me? And so, but that's a conversation for another day. But yeah, I will say that, that's probably the short answer is, I have my colleagues, and we're extremely supportive of each other, and because we're doing it every day, and so we see it every day, and that's, I'm eternally grateful for them.
Hi,
Whenever-
Scott. My name's Christina. I have a question. I'm also interested in more a general oncology rehab, and I am in a big hospital system. However, most of our outpatient, and I'm sorry, I'm also an outpatient. We get a lot of referrals for lymphedema. We have strength after breast cancer. However, like my goal is more like the general oncology rehab. What do you recommend, like for me and like other people, to like get our name out there, get the referrals? Like I have seen patients here and there, but like my biggest, I guess, barrier right now is like getting into like the hospital, especially obviously with COVID, and just getting the information to the general public. And like you said, like I'm also like pretty passionate, like for our knee hip replacements, you get that prehab, you get the post, like it's kind of automatic. But right now there's that, not at least in my hospital setting, there's not that automatic like prehab or post going on. So is there any like thing that you can help with just getting referrals, and like how, like what do you find works for you, or just getting out general information?
Yeah, I think that's something that we all struggle with on one level or another, Christina. Is your outpatient clinic, are you affiliated with that hospital?
Yes, but we're like the outpatient part of it, and there's like 25 sites.
Right. Okay. But you're still part of the network, so to speak.
Yes.
Okay. So this is okay. I'll tell you what I did. Like when I came on full time and I was trying to get my name out there, and it wasn't about getting my name out there, but it was about educating the clinicians, the oncology clinicians, that hey, we have an oncology specialist here now. Like I can help your patients. I can help your patients feel better and get stronger. I went and I presented at the breast tumor board. So the breast surgeons, medical oncologists, and radiation oncologists were all there. I got in there because my director from survivorship is a breast oncologist, medical oncologist. So she did help open that door so that I can get in there. But from there, what I did was I also went to some of our care centers. So Smilo has our main hospital, but we have like these like community-based care centers. And I went to those care centers and I presented to those doctors and that nursing staff, maybe probably at least half the time, if not 2/3 of the time, it's the APRNs and the PAs that are the ones that are physically filling out those referrals. It's not usually the MD, it's the APRN or the PA who's filling those out. And so I think if you're in this network, even if you're an outpatient, even if you're not in the hospital, you're still in the network. So to be able to kind of look through and see who's the point person, like, you want to reach out to somebody who's in the colorectal group, for example. Okay, look online and see who is that person, and then do that email. Like, I know it can be kind of tough to kind of put yourself out there, and I will tell you, like, the power of social media, right? I knew that at Smilo, we were getting a new director of our GI program from California. And I emailed her and I said, welcome to Smilo, and this is who I am. And she immediately, like, we set up a Zoom call and we chatted, and she said, oh, well, we have this new surgeon here, and she's young and she's got all kinds of great ideas. I'm going to put the two of you together. So she put the two of us together. And then the next thing you know, we're doing a presentation on prehab to the whole GI team. And so I think we do have to kind of put ourselves out there sometimes. But because you work for this big group, like, they're there. So it's just a matter of going out there and telling them, and you don't have to go into like, oh, what would you do for your valves or all that stuff. That's on us. We figure all that out, But if you can just say like, yeah, I'm going to work on fatigue, and I'm going to work on getting them stronger, both physically and mentally, like, they'll listen to that.
Thank you.
Yeah.
Hey Scott, I had a question for you. I was just curious the differences between like the pediatric population and the adult population, and if you've had any experiences with that.
It's funny, we were talking about that a little bit before we started. So professionally, okay, so I actually started off as a peds therapist, not in oncology though. And that conversation, I guess we'll have at the career chat somewhere down the road. But when I made the switch to oncology, I've been all adult, outpatient. And so I know that my colleagues that do pediatric oncology, they have a lot of fun. I remember all the fun that I had as a peds therapist, like using all the beanie animals for target practice and, all that kind of stuff. But those kids, they develop neuropathy, they develop foot drop, they become, deconditioned as well, and when you think about functionally for them, it's not return to work, but it's return to school, it's return to the playground, and so to think about functionally for them, okay, if this child has been receiving methotrexate, for example, as part of their chemotherapy regimen, they're going to develop proximal weakness. Well, that kid wants to go hang on the monkey bars with their friends. So that's what we're going to work on, right? But in peds, like you can make them do bear walks and all that kind of fun stuff. I can't make my adults do that.
So I know that you're in the outpatient setting, but I'm just curious your perspective on this. Like an inpatient, or I guess even just with certain oncology treatments, there's a lot of wait time. What have you seen physical therapy maybe being incorporated within, let's say, like chemotherapy infusion times, or like would that be contraindicated? Just a thought.
Steph, I love that thought. And I think that's a brave new frontier that I think we need to start exploring. The whole idea of, yeah, somebody's sitting in the chair, and they can't go anywhere. They have to wait hours for chemo to be infused into them. So why can't we put treadmills in there, right? Why can't they be walking on a treadmill while they're getting their chemo? Like even just the little pedals, right? Like the little pedals that we put under our desks, right? That's something. So, that would be it would be so groundbreaking, and it would shake up so many, of these established thoughts that we have right now. But it's exactly what we need to do. And you're right. That's in the chemotherapy setting, especially, like there are plenty of opportunities that we could be engaging patients. And I will tell you, like I do. There are a couple of there's one medical oncologist that I work with. He's great. He does a lot of cycling. Like he gets rehab. Like he totally gets rehab. And their medical oncology office moved from the second floor of their building to the fourth floor of their building. And he was all ready to put a gym in the second floor in that vacated space, because he said that would have been great. And of course it got taken before he even knew about it. And he was mad. And so we have these advocates, like we do have these docs that are like, oh yeah, that would be a great idea. So what I would say is, as you go out into the world, or even now, like as part of like your, if you have to do like, potential research, like a mock research project or community projects or something like that as part of your curriculum, why not propose that? Like to say, yeah, we'll get 10 of those little pedal things and we'll trial it in the chemo room, and we'll measure everybody's fatigue pre and post, or we'll measure, their their distress level. You can have them do a 5-time sit to stand pre and post and see if you get any kind of benefit out of that. Absolutely.
Well, I do want to respect everyone's time as well as Scott's time. Are there any last questions before we close it out? All right, well, thank you all so much for joining us tonight. This was super exciting and we were so fortunate to have Scott with us. And I hope it was beneficial for all of you just to get your foot in the door a bit and hear a little bit more about oncology rehab. And also a big thanks to Emma. She just turned her video on, but she has been so helpful in planning this event as well. So props to her. And please reach out if you guys have any more questions. Join us online, join the listserv to stay up to date. And we hope to have more of these events in the future with some more specific topics. So thank you.